So let's do the first one. Emergency department performance on emergency department throughput. I found this to be pretty amazing, or unless I'm really out of sync. So this is from the Annals of Emergency Medicine. These are pretty recent papers. So they were trying to use a database, U.S. Database, to look at, and this database is a national database, basically telling the world some key things about throughput and wait and total times in the department and total times for the admitted patients and discharged patients, door to provider, those kinds of core things in the operations of a department. And this ran from 2006 to 2016, a long period over which there probably was a fair amount of transition in terms of getting better or getting worse. And I think personally, there's been a bigger push on door to physician or door to PA/NP time now than there had been in the past, for sure. So some of the results of this for discussion purpose. The median wait time decreased from 31 minutes to 17 minutes. What hospital are we talking about when they say this is the national median wait time, 31 minutes, went improved to 17 minutes? Is that your experience? People wait a median of 17 minutes throughout the United States of America?
Well, yeah, but remember, you're looking at a lot of different hospitals. I mean, ours is probably 5 minutes, 10 minutes, and we're a 50,000 visit ED.
5 or 10 minutes.
Yeah.
Because you've got someone up front.
No. I despise that model. We just have nurses and APPs and docs who just bust their ass to get them back. I mean, but we'll see them in hallways, chairs, bathrooms, anywhere you can find them, but they'll get them out of the waiting room and just get them back. So yeah, I can see that as being not unreasonable.
Think your place is not typical. Any of your experience here? Come on, it's okay. We won't give out any names.
Yeah. Let me ask, do you guys have nursing ratios?
No. Oh, no. The nurse just gets, it's like a camel. You just keep putting more stuff on until they collapse.
Jeez.
All right, well, we're going to edit that out, obviously.
Yeah.
I work in a rural hospital, right?
So in a rural place with a good number of staff that you can basically see them quickly, yes. And there's about 1,300 and so of these, what do they call them? Critical access hospitals, where the number of patients may be skewing this thing a bit here, because I think, community hospitals are seeing 30, 40, 50,000. Maybe that's a little different situation, but maybe
That's really
each
good,
hospital
though.
counts as a hospital.
Really good.
I think, but when I look at these places, and look, we got absorbed by a health system, and the other place in the health system, it's like 2-3 hours in the waiting room, and we just can't conceive of it. But part of it is it's a culture that you can create in your department. We are not going to tolerate people sitting there, when we can get them back. So if you go through our department, you will never see an empty bed and there's somebody in the waiting room. It's an empty chair, bed, whatever. The APPs get a little upset because the nurses are motivated to do this as well. And they put somebody, in we have this row of chairs in front of an elevator where a lot of people get put with minor complaints. And, it'll be something in there and it'll be like a urethral discharge that they sat there. It's like, it's just tough for me to do the exam. Well, I can do it, and it's a real crowd pleaser when I do the exam here. But it's, we frequently get a complaint.
How about the length of stay, though? Has it addressed your length of stay in the department by first contact?
No, our length of stay...
Like compared to the hospital that does the 2-hour...
Oh, absolutely. We when they post the statistics, of course, all the other hospitals in the system, we're consistently really, really good, except for one thing where we are way outside, and that is from decision to admit to getting upstairs.
Okay.
And that's what absolutely destroys us. I mean, there are times when we have longer waits, obviously, and it's usually Monday afternoon when you've got a 30-bed ED and you're boarding 29 people.
Yeah.
That type of thing. But
Well,
no, go ahead.
Oh, I was going to say, you got to wonder how much of these are just the metrics that are like popped into the computer and how much of it is actually like first contact. Like a lot of hospitals that I've worked at, the first thing you do when you sign up for a patient, there's a little MSE thing that you gotta click at the same time, so that becomes your time to MSE. And before you've even seen the patient,
You're gaming the system a bit, is
well,
that what you're saying?
I think a lot of the computer systems are created in a way that demonstrate that group or
That
something.
encourage
So,
you to do it.
yeah, encourage you to do it.
I've seen sites where when it gets to a certain point, the one of the clinicians is sent out to the waiting room to greet everybody.
To walk around, say, hi,
Yeah,
good morning,
yeah, hi,
I'll
yeah.
be your physician today.
I'll be your physician. I'll see you in about 6 hours.
Yeah.
Type of thing. But then they go back and they
Click,
it
click,
off.
click, click, yeah.
Oh, look, our wait times are almost nothing.
Well, we have 180,000 a year that comes through the
Right.
county hospital. It is, these numbers are inconceivable for us.
180,000.
We'll have, routinely have the waiting room, 60 to 100 people waiting in the waiting room. It's just
Waiting, 60 to 100 waiting.
60 to 100, yeah.
Yeah.
And so, like, for us, we have to have providers in triage to MSE every single person that comes through, and then we try to get close to these numbers just through that process. But
I think
there's
it's
so
not
much
the number.
variation.
It is really a culture that you create in the department. And it's not just a person. It's like every clinician from top to bottom. And periodically we will have somebody, a new person comes on board, and they'll be chit-chatting, and the other people say, what the hell are you doing? You've got these responsibilities. Get moving on them. Our staff is really proud of that part of our department. And I think that's part of the key to it. The whole team buys into it. Billy Mallon used to make a really good point. He said, even in the hospitals that have long wait times, when you get to the night shift, everybody's on the same page, which is, let's get the waiting room empty, because if we can get the waiting room empty, we've got, that time from 4 a.m. to 5 a.m. or whatnot, where there's a little bit of downtime. And he said, you watch it, they just come in and the night shift just cleans everything out. Where the day shift, it was kind of getting to the end of a 12-hour shift, and they're just like, I just cannot take one more belly pain, So yeah, it's a cultural thing, even within shifts in the hospital or in the department.
Well, Al and I have been doing this for probably 20 years, and it's very clear that he has an exceptional department, and it's all about the culture of the place. They go bowling together, they do bike rides together. Al brings the sausages in on Friday afternoon kind of thing. The potlucks, this is unusual, I believe, and I think it's reflected in his leadership of the department.
Leadership.
And, this is a kind of a tough question. Is there a difference, do you think, about how many patients per hour, or how do you clean out the department if you're an employee versus a contractor? Do you think there's any difference there? Employees, my shift is this, my shift ends here, or the
No, I don't
independent
think so, 'cause
contractors basically get paid on what they see?
I don't think so, because you've got similar metrics as mine. The nurses are employees. The docs are fee for service, whatever the hell you call us. But they behave the same.
So in our system, we went from a fee-for-service system to a majority of the hospitals in our area for the physicians to a hourly fee. And they found that physicians were very similar to other individuals, where if you paid them X amount of dollars, whether they saw 0 patients or 10 patients in an hour, it changed behavior. When they were on that fee-for-service model, they were cranking through the bodies, and the metrics changed as soon as it went to an hourly rate. And so then they had to come in and put in some modifiers with regards to it. Anywhere between 10 to 25% of billings we call them shadow billings, would be a bonus for throughput.
Well, at lunch yesterday, we were talking with a woman who works in ER, and they were looking at comparing Al's place with their place in terms of what the number of patients they were seeing per hour and the throughput and all kinds of metrics that they had. And they had twice as many staff as Al had, half the staff that they did, and moved the same number of patients in a similar amount of time.
But it's also the people who want to work there.
Yeah.
We've had people come in and just go, this isn't for me.
I can't
And-
do
Right.
it.
Yeah, and I'll bet at your shop that includes nurses too. Nurses and APPs and everything else. They just come in and go, this is not the place for me. And others just thrive in that environment.
Well, the
So-
thing that's really impressive about the way that you talk about your place is that a lot of times there's an inverse thing where, like, the more patients you're seeing, the quality of care goes down. But you know, in Al's shop too, there's the connection, the way that you talk about it all the time, how important it is to patients, our community, and connecting with the patients also matters, because you work at a lot of places where the throughput is fantastic, but like
Quality care is.
quality of care is awful.
Suffers.
And I don't know. How many of you folks are looking at these numbers, 31 minutes, 17 minutes, and that sounds about right for your place? Raise your hands if these numbers are about what you're seeing.
Yeah, see?
Wow.
What's that?
Before, yeah.
Before
Right,
COVID.
right.
Yeah, excluding COVID.
That doesn't count, yeah, that's for sure.
You know, when the census went to 3 people a day, yeah.
They even know about boarding times, 75 minutes boarding time, however you define that, I'm not exactly.
That I
sure
don't
what that is.
believe. The 75 minutes
From
boarding
clicking
time.
from admission till they're
You, s-
gone.
s- you believe some and don't believe others.
Yep. No, well, I'm just going to say that in my experience, at our shop, but every place I talk to says, you know, boarding is just a huge problem. That, you know, nobody gets the admission out of there in 75 minutes. Boarding is usually defined from the time you make a decision to admit them until the time they leave your department. 75 minutes, you know, unless they have a little hole out back that you just keep wheeling and dropping bodies into, I find that hard to believe. Anybody here get them up in 75 minutes? No, see?
One of the things about Ramin is, although he works at an academic place now, he was for 6 years working in the community as a community doctor, so that he's got both perspectives. Any further comments? Should we move on? All
So
right.
number 2 is urgent care centers deter some emergency department visits, but on net increase in spending. So this was looking at insurance claims and looking at zip codes and trying to figure out what happened to the low acuity patients in the emergency department if there was an urgent care center. And did it have an impact on the volume of the patients that showed up in the emergency department? And the answer is it did. It had a small impact. For 37 additional urgent care visits, you got 1 less non-urgent patient in the emergency department. So 37 to 1. Then they put a number on this with regards to a dollar figure. Each low acuity ED visit was $1,600. And it was offset by a $6,000 increase in UCC costs. So despite the fact that it was a 10-fold higher price for the ED visit, the overall spending went up because you were seeing a lot more, like 37 more patients in the urgent care clinic for that one diverted patient, I guess, from the emergency department that was low acuity.
I guess that applies for systems where you have the system is going to try to kind of unload the emergency department and move them over to an urgent care center, and they open it, and it's flooded with patients from the outside, which is, in some ways good, in some ways is not particularly good. It relates to access.
Yeah, I was going to do number 3 at the same time, and then we'll talk about
They were
it.
actually in the same issue of Health Affairs,
Yeah.
which is this snooty health policy publication.
Is that how they advertise on the website?
That's right,
We are a
snooty.
snooty,
Yeah. There's somebody in there with an ascot and a blazer.
a little
holding-
what in the
yeah,
pocket
yeah.
thing, yeah.
Yep. Number 3 is I guess it's more in line with what some of us have seen. They did the same study, which is looked at zip codes, and then looked at visits, or what happened to the patients in an emergency department when you put it in an urgent care center in the same zip code. And what they found was that having an open urgent care center in a zip code reduced the total number of ED visits by residents in the zip code by 17%. And that's about what we saw when all these urgent cares opened up. And the large decrease was for less emergent conditions. The only thing that was a little bit funny was they found that the urgent care centers reduced the total number of uninsured and Medicaid visits in the EDs and by 21% and 29%. Our experience, and tell me if yours is different, the urgent care centers don't accept uninsured or Medicaid patients. So what we saw was our insured patients all went there, and they were actually encouraged to go there by the insurers, and the uninsured still came to the emergency department. That's the thing that doesn't have face validity. I don't know what your experience has been with that.
Well, I work in urgent care, so we see a lot of uninsured.
And if you've been on, you didn't have insurance and you've gotten hit with a $3,000 ED bill, it makes a lot more sense to do that if you know there's a finite fixed cost.
Cap out at 500 if like they need a cast or they need other.
That, I mean,
Can you summarize?
would make sense.
Can you summarize it so we can record the question?
yeah,
The answer? Or the-
yeah, this physician, APP.
I'm a nurse practitioner at Physicians Meeting Care.
Okay.
There's a bunch of them in the Midwest.
Okay. A nurse practitioner brings up the point that it's not surprising that the uninsured stopped going to the ED because the urgent care has an ability to prorate their costs based on whether you have insurance or not. And so you can get seen for an urgent visit for $100 or so versus, as Raman's pointed out, $3,000 for the same visit to the emergency department.
Yeah, that's for cash patients.
Right.
Medicaid patients, doesn't matter where they go, and so they're more likely to go to the ER if they think they'll get seen quicker. Otherwise, urgent care is, if they're accepting Medicaid, which I don't think many do.
Yeah. The other thing that's interesting is the insurers will encourage them, and some of them have relationships with urgent cares for that very reason. They can get seen for a cheaper price there. But they don't make distinctions real clear as to what goes there or not. And I'll throw this question out there. How many people see a significant number of patients with chest pain complaints who have had a cabbage or they have stents and everything else, and they went to the urgent care first and then got, the urgent care appropriately directs them, to the emergency department? Yeah.
Everything.
Yeah. Yep. A lot of people are saying that. Yeah.
It seems to me like the urgent care center, and then the cost just goes up for the urgent care center as well.
It's interesting.
Repeat her
Oh yeah. So the point was made that originally these urgent cares were planned to be staffed by APPs, but more and more we're seeing a trend where physicians are staffing up a lot of these urgent cares, and we've seen this locally in Los Angeles, where a lot of former ED docs are now opening up their own urgent cares, and whereas urgent cares had minimal resources, like you could go there and maybe get like a suture taken out, get a splint, things like that. Kind of like a fast track kind of area. A lot of these new urgent cares that are popping up have a lot of, they have imaging, they have labs, they have all the different things that you would want. It's like a little mini ED light. Not to mention the freestanding EDs that probably a lot of you are seeing as well. I think there has been a paradigm shift for sure. And I think it's confusing to patients. Like, well, if they have labs and they have imaging and if I have chest pain, why wouldn't I go to the place where I, would wait less? And a lot of partnerships are developing between the big EDs, and they have these sort of satellite urgent cares, and their docs sort of like are floating around. I've said for a long time actually that this paradigm of ED docs, like as we progress in careers or ED providers, it would be nice to have sort of an urgent care model as like a soft landing where you're not doing nights and late swings and whatnot. So I'm not totally opposed to these models where these satellite urgent cares, but it's a process and evolution. There was a question?
I was going to say, when you talk about urgent cares, the definition of just there for a minute, they're very minimal.
Well, there's a big push in the minute clinics for primary care too. They would like to follow your blood pressure, and it's not just about coming in there for a Band-Aid on an abrasion or something like that, because primary care means recurring visits that you can kind of depend on, and it's not only in these minute clinics, it's urgent care centers that are expanding to do, urgent care doesn't even apply anymore. It's just a walk-in kind of place, but they reschedule you. You don't have a primary care doctor, we can take care of that.
I think with COVID though, what you were saying that over the last 2 years, I think you're going to see a lot of people that have been working in the emergency department not wanting to work in the emergency department once this is over.
There was a survey, this came out like 3 days ago, it said 23% of people working in the ER said that they're going to leave.
They're going to tap out.
23%.
I get that vibe.
The other thing is, I think that with COVID, a lot of people, all of us, I think, recognize, when the first alpha hit, you know, a lot of our censuses just dropped precipitously. And none of them really rebounded completely until Omicron hit when everybody went through the roof. But I think a lot of people realized that what they were going to, either urgent cares or emergency departments for, they were seeking care, got better with just a little bit of as Ken calls it, tincture of time. And so now that you don't see this knee-jerk response of, oh, my kid's got a fever, I got to get him seen immediately. Now it's like, you know, they had a fever before, I waited it out, and they did fine. So, you know, I think we're going to see a little bit more of that, people not coming to the hospitals or the urgent cares immediately because they got some experience with, gee, I don't need to.
But the hospitals were also saying, well, where are all the chest pains? Where do they go, you know, over a 2-year period, you know?
Well, I was, you know, walking across the street for dinner last night. There's a teledoc right across the street. I mean, this paradigm of emergency care, whether it's urgent care, telemedicine, all this. I mean, it's going to be interesting to see where this goes in the
This is
next
just
5
like
to
a
10
big
years.
screen across the street, or
A teledoc?
It's the teledoc. It's one of it's probably the largest telemedicine group for emergency medicine. A colleague of mine actually moved to France and works for them. He does his overnight shifts during the days in France and gets paid the overnight rates from teledoc. But
Just like the Nighthawks did with the imaging
radiology,
studies.
right? But he's an ED doc that has shifted to full, 100% telemedicine. And
All right, should we go to number 4?
number 4 is a completely different topic, maximizing the morning commute, a randomized trial assessing the effect of driving on podcast knowledge acquisition and retention. So this is published in the Annals of Emergency Medicine. Gottlieb et al. One of our colleagues at LA County is actually on this paper. I remember they were recruiting some of our residents to participate in this, Jeff Riddell. So they, if you want to listen to Ken's podcast and you want to know, am I actually going to retain this on my morning commute, or do I need to sit in a undistracted room with, like a library style setting? Will my knowledge retention be the same? It turns out that, these folks studied this. They enrolled 100 residents. They randomized them to either driving and listening to a podcast or being in an uninterrupted sort of like space, quiet room. And then they gave them a questionnaire or a test immediately after. Then they crossed over the groups, and then they gave them a test after that, and then they gave a delayed test, a month later. And it turns out the groups did the same. I think ED docs are used to working through probably plenty of distractions. So, in fact, I think I probably retain knowledge better when there's a lot of chaos going on. I don't know about you guys. Interesting little study.
So I have things to say about this one.
Talk to us. Talk to us. Go ahead.
As somebody who does a podcast and
Yeah.
runs a blog, they're not all the same, right? And so they didn't discriminate what were they listening to, right? And some shows just sit down and have a conversation about pneumonia in children, right? And they don't follow the evidence for education and adult education. And so I try to follow that information that says you've got to keep the show short, you have to have spaced repetition, and it's not just the blog and it's not just a podcast that they listen to. Each day there's something new that comes up. And so today is Saturday when my podcast or my blog goes up on Saturday for this week. Sunday the podcast goes up. Monday, I challenge the audience to come up with memes that summarize the whole show. Tuesday is an interactive Twitter poll that goes on that asks a question about that episode on the podcast. Wednesday, the results go up. Thursday is an infographic that summarizes the whole paper into one picture. And then Friday, I challenge the audience with giving them the PubMed reference and asking them, what 80s song do you think I'll sing? And so it's not just a one-off, I listen to a podcast in a car.
how many people have accidents listening to?
I do give trigger warning and say you better pull over for this one.
This is a commitment, though. Ken.
No, but so it's not just so like when they say, I agree that if you just listen to something passively in a car, depending on how the information is presented, like we've all gone to lectures, right? And had a lecturer come up and just monotone on, and when you leave, did you learn anything? No, but we've had great speakers and dynamic speakers and that connected with you and that gave you stories and a narrative and had spaced repetition, and you left and you remembered that, right? You remembered that experience. So, well, I agree that in general, listening to a podcast on your commute to the shifts may not have an impact in knowledge retention, but it can.
I think the other thing is what you're listening to. Like you said, if I'm listening to a conversation type of lecture, I can listen to that. If I'm listening to somebody who's going to get into like, you know, the right dose of this is 250
Yeah.
milligrams, unless they have these circumstances, that's a little bit more difficult for me.
Yeah.
And that's the one where I'll stop, you know, at the end when I get wherever I went, and I'll scan back to the notes and look at it. The other thing is, and this is a very real phenomenon, you're driving and you're looking for a particular place, and how many people have turned down the radio while they're looking for that one spot? We all do. And so I think if you're driving and you've got this going on, but you're also trying to pay attention to, oh shoot, there's a detour up ahead.
It didn't
am I
measure
going?
that, right?
Yeah.
Like how many missed exits were there or
Yeah,
something.
exactly.
And which car were they driving? Were they in a Tesla, level 4 autonomy, you know?
But it is an interesting point, because when we talk about all these different studies that we're going throughout all the EMA chapters, one of the most critical things to look at is what was that target population? Can you generalize that population to a broader population? And so, you know, it's a point well taken that what type of podcast may not generalize to all other podcasts, but interesting study nonetheless. Number 5.
5 is asking about, do you see people quicker at the end of your shift than at the beginning of the shift? So that with the good intention that you don't have to have pass-ons and you got it all wrapped up. And this, now that may be not the reason that this occurs, but this study looked at these median time to disposition. For the early part of the day, it was 3.25 hours for a disposition. At the latter part of the shift, it was 2.6 hours. So it's a big difference, actually. It's a half an hour or whatever, however you do that, in terms of quicker getting out. And they attribute it to potentially the idea of wrapping up your shift, not having a passion on patients. I'm done with my work. There may be other reasons that are the cause of it, but it basically suggests that our pace does not stay the same all day. And if anything, you seem to be faster at the end of the shift.
Yeah, I mean, there's some confounders. You might be picking up, you know, more fast-track patients toward the end of the shift, of course, but I think this is such an important thing that I try to stress to residents all the time pre-sign out. Try to remember that the patient that you're seeing at hour 7 of your 8-hour shift, treat them the exact same that you would the person in hour 1. I don't think we necessarily do all the time. I can tell you personally, every like terrible case outcome that you know, so many of them have happened at that
Right at the end of the rush.
back end where you're kind of rushing through, and maybe you didn't do that, take that extra time to do that extra physical exam or to observe them as much as
Or
somebody
order the test.
needed.
You know, it's normally I would order a CAT scan, but I don't want to wait around for the results.
For the
on it. So, yeah.
Yeah.
So, yep.
But, you know, you can staff and do your shifts and you know, like being in high acuity at the start and then fade off into maybe a fast track near the end. But, you know, how many times we have a blue zone or something, you know, in one shop, how many times do you walk in and it's, you know, it's a sprained ankle and it turns out to be a STEMI, you know, in fast track. You know, how many, like low acuity, and it turns out to be, oh my goodness.
See, I do the exact opposite. The shift before I came out here was like 20 minutes before the
start
end of
fast?
the shift. No, they said, you know, there's a code coming in. There was 2 of us working. I said, let me do the code. And he goes, fine, you're done in 20 minutes. It's like, I'm either going to call this thing in 20 minutes or they're going to be done, and I can admit them. So there's no waiting for any tests to come back. They either got back the ROSC or they didn't, and we're done.
Okay.
And so, yeah, it was like, no, the lines are in, you know, and call upstairs, call to the intensivist, hey, you know, this guy's, his A-line's in, his CVP's in, he's got, you know, a blood pressure. That's it, yeah. So I find it easier to take the sicker people at the end. And if you have to sign a sicker patient out, my feeling is it's real easy for me to sign out like, this guy looks like their urosepsis, their blood pressure is really soft, they've gotten, you know, 30 cc's. And the oncoming doc goes, okay, I got the whole picture. And, you know, I'm going to see which pressor I'm going to add, and, you know, maybe we'll put an A-line in them. But that's a clean sign up versus, I got this person with this funky chest or belly pain, and I'm not sure which way they're going with it. And I was kind of thinking about this. And when you pick up that patient, you're the exact opposite. You're like, oh, he said he was kind of thinking about, you know, a stone. I don't see a stone. Maybe I'm going to get him out of here. You know, I better go back and relook at them. I think it's easier to sign out a sicker patient than it is a kind of soft patients.
It's interesting, and I think this goes back to the whole culture. What's the culture at your place, and or surrounding transitions and whatnot, and do you feel bad about it? I just had, a case 2 weeks ago at the little community shop that I work at once a month, and I was oncoming at 6 a.m. The overnight doc gave me a sign out. He's like, "Hey man, I'm so sorry. This guy has just back pain. He came in an hour before the end of my shift, but like he has a dialysis fistula and he has a little bit of radiation. I didn't feel like, and I'm like, what are you apologizing for, man? Like, no way." And the guy ended up having, had an epidural abscess. Like 4 hours later, I saw him on shift again a month later. I'm like, thank you for signing it out the way that you did, and I'm glad that he didn't try to dispel that person. But the culture is so important, or of like how willing are we to like be like, hey man, don't apologize for these.
The person we talked to yesterday, we were at lunch yesterday. It was fascinating. She worked at Mayo here. Yep.
Where was that? No.
I'll give you a pause to edit that out. Okay.
Please cut that out.
The person we talked to yesterday worked at
Write that down,
a
Michael.
hospital, and they have a system where the computer assigns the patient in the waiting room to a doc. Now they have a lot of coverage, but it assigns them to a doc. And so I said, "What about sign-out?" She goes, "Well, they stop assigning us to anybody 2 hours before the end of our shift." I'm like, wow. I mean, but if you've got single coverage, how do you?
Yeah.
I stopped seeing everybody 2 hours before the end of my shift. You can't do that.
No, actually, at some of the bigger hospitals, one of the other faculty members who worked in Canada in Toronto, they have a hospital where they have what's called waterfall shifts.
Waterfalls, yeah.
Do you have any of that at all? Because these waterfall shifts basically have the next doctor coming in 2 hours before your shift ends. So that gives you time to wrap up the cases that you're working on, get all your charting done so that you actually walk out of there on time, charting done, complete. I don't know whether that's because they're employees and they expect to leave on time kind of thing, but the waterfall shift idea.
It's because they're being paid an hourly rate, and so we have fixed shifts, so you're...
hourly.
Yeah, so you're on an hourly rate, and so we have, at the one place I work, we have those waterfall shifts where we have it staggered, where the person comes on at noon, and then another person comes on at 2, and then, the original person is gone, and then, and you just, for the last 2 hours, you're just cleaning up. Because you're not gonna, if you stay an hour late, you don't get paid for that hour.
Yeah.
You stay 2 hours late, you don't get paid for those 2 hours.
Yeah, here in the States, you hear about all these people doing charting after their shift's over, and so their shift is really longer than it is. In fact, somebody here is doing charting, attending the course.
Yeah, some people chart at home. I did not my thing.
Well, speaking of culture,
Yep.
this is abstract number, what is it, 6?
Yep.
Yeah, this is
Do
looking
6
at
and 7 together.
the glass ceiling. And so the gender distribution of leadership among emergency medicine residency program. A friend of mine encourages me to say, we should stop measuring this and start doing something about this. Because everywhere we've ever looked and everywhere we've ever measured, there's a gender gap, right? So let's stop measuring it and start doing something. But this, again, quantifies that in the emergency department, cross-sectional study, looking at program leadership from the chair to the program director, the assistant program director, the clerkship director, and who had these positions, and there was an apparent gender gap with regards to the senior leadership in U.S. EM residency programs. 10% of the chairs, 35% of the PDs, 41% of the APDs, and we have 50%, or sometimes in emergency medicine, more than 50% female physicians, and so we still have a gender gap. But it does.
But, all right, hold that thought, because his comment was that gender should not make a difference. You're just treated by
Meritocracy.
performance. Yeah. Because we have to do number 7, and then we'll go back to your thing. Salary disparities based on gender in academic emergency departments. Here they looked at 154 emergency departments over a 5-year period, and they looked at really here more the percentage of women in any leadership role was significantly less than men. Now it's interesting because the difference is 44% to 55%, and I would have thought it would be a lot larger when you looked at these numbers. But the other thing that they found was that there were salary differences as well. but you also found that women worked more clinical hours. They tended to work 48 hours more per year than men, which, again, I thought that difference would be a lot bigger. One of the things and this is not unique to emergency medicine. This is unique to anywhere you look. You'll see that. I have some relatives who are lawyers, and they said, this issue has come up in the legal profession as well. And one of the things that's come up, and it's kind of interesting, is we keep trying to equate males and females the same. And in terms of clinical performance in the emergency department, or clinical performance, like you said, in a position as a VP, a CEO, whatever position you're in, there clearly is no difference. I mean, whenever you blind a study as to the gender and you look at performance, performance is always there, that it matches out the same. Where the difference comes is outside of that, and preferences there. And they did this study in New Jersey. New Jersey ASAP did this study, and they looked at salaries for emergency physicians in all the hospitals. Everybody reported it, and I forget. And they had a very good response, because they were looking at this, and sure enough, they found exactly what you would expect. There was a disparity difference. But then when they drilled down, what they found was more of the females opted not to go into a partnership track, but wanted to go in, I guess, I don't know about how this works. Some hospitals have partnership tracks. Some, the group that ran the hospital had a partnership track and didn't. And that turned out to be a very significant difference as to the preferences of the type of practice that they wanted to go to. So they opted to stay as an employee of the group rather than go in the practice track of the group. And that accounted for part of the difference. The other part of the salary difference was who wanted to work fixed shifts. Like they had a fixed number of shifts that they wanted to work versus not. And more of the women wanted to work fixed shifts so they could allow more family time at home. It was more important for them than it was for the men. So they found real differences there. They couldn't find a difference in performance, just like everybody said. But there are social preferences that did show up when they did their analysis. Now, whether that's forced on the women to make that decision, that they have to be more available at home, and therefore they can't do the practice track, they have to do a fixed shift track or not, they didn't explore, and that may be a good explanation for it. It's not a elective decision on the part of the woman to practice in that pattern. They have to do it that way because whatever their relationship is in terms of their family, they don't have the same options of not being home as much or something along those lines. So they found that some of these things really aren't related to performance in the department, but it's an external force that's influencing decisions, active decisions, on how the practices map out. And I thought that was kind of interesting. What I find fascinating is in our department, for most of my career there, when I was the director, I'm the clinical director now, and the new director is a woman, it was always about 70% female, 30% male for all our practitioners, the APPs and the docs. And every woman we lost because they took an administrative position somewhere when they went, except for one. So, when we look at it, it's like, well, we did okay. I'm not sure why these other places aren't.
Yeah, but that's, that goes against the national trends. And when you look, the national soccer federations and everything else,
yeah.
and then pay differentials. I mean, there's a lot of.
It's not just in this field.
Yeah.
No, in healthcare, women make up 80% of the workforce in healthcare, 50% of med school enrollment, 9% of division chiefs, 6% of department chairs, 3% of chief medical officers, and 3% of CEOs of hospitals.
What are you trying to say?
That there is a gender gap in the House of Medicine. Now, if you want to talk solutions, Dr. Lois Lee out of Harvard put together a consortium and has what worked for them. And I did a show on that with her about 2 months ago, and it's on the site, and it was published in Academic Emergency Medicine, their consortium, on how to address this and how to try to figure out how to make it a more inclusive work environment.
Any experiences here that you'd like to talk about?
I did a show with a husband and wife, and they were both going through emergency medicine residency together, and graduated at the same time, worked at the same had the same residency site, and then took a job at the same place. And they were on the same track until she got pregnant, and then they didn't have pregnancy leave. They didn't have adequate accommodation for breastfeeding. It was based on service, so if she had to take off and go and breastfeed, and the only breastfeeding room took you 20 minutes to walk to pump and then come back and things like that, of course her income went down. And so it took place in a context, and we just have to, I'm not saying that there's necessarily easy solutions, but I think it's something that we should be actively working towards. If you set up all your administrative meetings at that time between 7 a.m. and 8 a.m., and that's, for the people that have children, that's the time to get the kids out. How many people get called on shift to come and pick up a sick kid? Have you ever been called to come and get a sick kid?
Yeah.
Yeah, exactly. Take care of them on your own. But there's a trend, right, with regards to, well, you're the woman in the relationship or something like that. And again, I'm being heteronormal here, but that it falls more towards women than it does men, or females towards males.
It is interesting though when I look, and I don't know, we must be outliers. I mean,
You are. You see
You're,
your patients
in many
quickly.
ways,
no.
you
I mean, just the institutions that leadership roles across our institution have a lot of pretty much almost an equal mix there. But I will say that the personality characteristics of the women I've seen in leadership roles, and the ones who actually, I should say really, the ones I respect in leadership roles, are identical to the same characteristics of the men I see in those roles.
In respect of those.
Yeah.
roles. Good.
I think there's a macro thing and a micro level
Yeah.
situation here. On the macro, we're looking at the statistics, but the micro goes right back to the culture that everybody's talking about. I have one of our APDs, assistant program directors, just got a promotion. Is up for getting a promotion somewhere at the medical school, and she's carrying right now, and it was a big thing. Should I talk about this? Should I not talk about this? This should not be on her mind at all.
No.
That should just be completely taken out of the equation. And fortunately, I think we have an institution, that it's going to. And I told them, look, the people that you're talking to are going to be like happy for you and excited. And this should not in any way prevent your career trajectory. But the cultures are heterogeneous across the country, and we just got to move toward improving these cultures on a micro level and on a macro level, and keep at it.
Three of the last 4 women we interviewed for positions, and who took the positions, were pregnant at the time of the interview. And none of them had any, concern that was going to make any difference. And I think it had to do with the way the interviews were going. It was, when they sat down to the interview, just the nature of the interactions, it became incredibly evident to them from the opening statement that, hey, great, you're pregnant. It makes no difference, whether we're going to hire you or not. We think this is wonderful. And all of them, we made arrangements for, you're not starting at the time we wanted to have you start because, it's too close to your delivery date or whatnot. And when you're ready to come back, we'll cover your shifts until you're good to go. And all of them came on and had, what's the name? Stayed with us. So.
You had a
I think, some young women, some gender gaps and pay gaps and different things happening. I'm not sure what's right, but.
But I think you made a good point, and what she said was, as you move through your career as a woman, you've got to make decisions, how much of your time is going to be committed to family, how much is going to be committed to career. And it's not just emergency medicine. This is every field. You've got to make that decision. And that is a real problem that men frequently don't face, mainly because that culturally, at least in this country, it's been the family's been the responsibility of the day-to-day responsibility of the woman, and the guy was just able to leave and just go to work and stuff. You see a lot more younger couples with a shift where there's a lot more shared activities, and as much emphasis is placed on the woman's career as it is on the man's career. But one of the things that you see across the board is, and where I went to medical school, was the Medical College of Pennsylvania, which previously was the Women's Medical College, and they specialized in getting women into medicine. And my class, when I was there, it was 50-50, which was unusual at that time. But in addition, the average age of the starting student was almost near 30, which was compared to like 22 at most other places. And that was because we had a lot of women who had gotten their family to the point where they could step back. The kids were all in high school or something like that, and now they entered into the medical career, and this is back in the 70s, so that's just the way it was back then. And so what you see is, no matter what field, not just medicine, across the board, a lot of women kind of have their foot off the throttle as they're going through their career, managing the family, and then as soon as the family is kind of a little bit autonomous, put their foot down, and now their career takes off. So you see this, it's not just a gender gap, it's an age gap, where men are accelerating their career from day one, where the women don't start to accelerate their careers until 18 years later, when the kids are a little bit older. And again, that's a cultural thing in the country. That's the way this country is, and it's changing. It's going to change slowly. But you see, the other thing that we see a lot of now is women with, I guess, financially better career paths than the men, in which case the family structure changes. The male steps back and says, yeah, I'll stay at this lower level, and you take off because it's just better for us.
Moving on.
We got a long ways to go on this conversation for sure.
We're not solving this one today.
Abstract number 8 is understanding patient preference for physician attire. Interesting, coming for ED docs to read. A cross-sectional observational study of 10 academic medical centers in the USA. This was published May 2018. This was basically a study where the authors surveyed 4,000 patients from 2015 to 2016, and they showed 7 different pictures of different attire with doctors, and they asked for all their preferences and whatnot. More than half of the respondents felt that the MD attire was important. A third felt that it affected their satisfaction of care. And then when they sort of asked about particular preferences, the preference that came up most often was formal attire, particularly a white coat. That was the most highly rated. But then when you looked at what level of respondents had that preference, it was mostly in the 65 and older range. This is a fascinating topic, I think. And I wish that we had something a little bit more focused on in the ED, because I don't know what the rate of scrubs to white coats is, but I'd imagine it's pretty low. I don't know, how many of you are white coat wearers in the ED?
How many wear scrubs? Yeah.
Right.
Everybody wearing clothes?
Well, the other question,
Patagonia,
how many wear
bike helmet,
scrubs
and a white coats.
Yeah.
Occasionally.
That would be
The pockets are why you wear the white coat. Take advantage of that. We had and I'm looking at there's I think it's a 50% mix here of women to men. How many of the women here have problems where the patients don't identify them as either APPs or physicians, and just consider them as nurses, because traditionally they think that's the way things should go? Yeah. And how many have male nurses that are consistently regarded as physicians?
How many men have been mistaken in this audience for a nurse?
I have.
Yeah. As an orderly. Yeah.
An orderly?
Yeah. So, yeah. But it is true. And we actually, and again, it's a culture thing. Ours is really not that bad, because we've got our nursing staff is almost 50-50. Our physician staff is more female weighted than male weighted, or our clinician staff is more female weighted than male weighted. And we rarely have, every once in a while, will get that complaint, I was never seen by a doctor, you know, and it was seen by one of the female physicians or APPs. But it's not the way it was, like, you know, 20 years ago. There was a much bigger problem. Now it's not as much of a problem. But I know it still happens because we really literally had to script the females, members of the APPs and the docs, to say, make sure you identify yourself, you know, because of that. And, you know, our population's a little bit different. They're just happy to be treated, so they don't care.
Yeah, like us at the county hospital, sometimes we argue amongst ourselves, like, do we want to be seen as the, like the ivory tower, like white coat type, or do we want to connect with the patients and be able to just, but I don't know the answers to these things, and it is really great that they're actually asking the patients. We have a comment here.
I was just gonna say that,
Who knows?
introduction.
Yeah, and it's interesting. I've seen a lot of EDs now where on the badges they have these big red or something that says physician, nurse, so that people can see, because it's so hard from a patient perspective to see who's the person with the red scrubs, who's the person with the black and the blue, and I think it is a little bit confusing for them.
But this woman made a really valid point.
Really.
It's when you open your mouth, you've already established what you are. Yeah.
That's not my experience. I used to wear a white coat, said doctor, doctor.
Right.
I literally went to the whiteboard, wrote doctor, and they still didn't.
Yeah.
Yeah.
So I gave up.
Yeah. Yeah. But my preference is I wear the white coat because I love stuffing stuff in the pockets. It's about the only reason.
The next one is on the same topic.
Yeah.
Yeah, it is. You know, there's been a whole bunch of studies like this because it's so easy. You just take the pictures of these people, and then you send out a survey, and you get a response. And I've looked at a bunch of them, and sometimes it's white coats, and sometimes it doesn't matter, and it's not necessarily in the setting of the emergency department where these are done. And so this is from JAMA, which is another, you know, kind of big deal journal. This is a study that was done on Amazon. They have some kind of mechanism for doing studies there. And this is 487 people responding to the pictures of the people wearing scrubs and white coats and the like. One of the things that was really interesting in this is that the average age of the respondent was 36 years old. And I do think that that's really important, because you were mentioning you would think that the study involving older people would like white coats, and the younger people, you know, anything goes. But in this study, they basically like the white coats in terms of reflecting professionalism scores, and they viewed the people as significantly more experienced. And I think that, you know, in emergency medicine, you'd like to have about 5 nanoseconds to establish yourself as caring, competent, those kinds of things. And it's like, well, one of the things might help in that is a white coat. It's not like essential, but it might help. And so you're looking for everything that you can do within the first 5 nanoseconds to say, I'm competent, I'm caring, I'll take care of you, you know, you're in good hands. And I think that personally, that's why I don't know that it is, it's probably a generational thing, but I think the white coat's a good place to carry your stuff.
But it's interesting. How many people flew here, and on the plane, you got bored and you flipped through the magazine in the back there, and you hit that section of the top docs in America, and you look at the pictures of them, and all the cosmetic people were just, you know, cosmetic surgeons and cosmetic dentists and stuff, male or female, were just impeccably dressed and, very, very professional looking and everything else.
They're the ones having the fancy buffet every morning and breakfast.
That's probably true. And I thought it was fascinating. Nobody was in scrubs. Nobody was, down to earth. They were just, extremely professional looking, or I guess Hollywood professional looking. But you told me the story of the guy, the plastic surgeon that you asked them to do a consult on a patient in the ED with who is it? You who told me? That they had a facial laceration that the family insisted they wanted a plastic surgeon, and you had called them, and they were coming out of the OR, and they were in scrubs and stuff, and they said, okay, I'll be back in a minute. Went upstairs, got cleaned up and came down like in the perfect shirt, shirt and tie and everything else before they went to the bedside to talk to the family about the 1 centimeter laceration on their kid's forehead. So, yeah.
You know, if this was done in a doctor's office kind of thing, that might be a different situation where they would expect that you would wear a more, they even mentioned it here that you would be wearing more professional attire than not. So what we need is a nice ER survey in different places, because your place is different than, you know, some of the more affluent, necessary people where the expectations may be different.
Yeah. Mayo Clinic is different than a county, yeah.
How many people here are primary care? And in the primary care offices, they've stopped wearing ties. Everybody's open collar now. Yeah.
Fomites?
Yeah.
Because of,
Well, no, I think, yeah, that's true. You can make the argument for it, but they just stopped wearing ties and stuff. You're more, they say you're more personable when you don't have a tie on.
It was the surgeons who first adopted the white coat.
Really?
Yeah, so the white coat was co-opted by science, or from science, right? So this was when the Flexner report came out over 100 years ago, and we had all these different kind of medical schools running around in the US, and you could graduate as a physician with a 1-year degree. And the Flexner report came out and said, listen, we need to like up our game here. We need to really get strict about training and programs and certification. And so the white coat was adopted because scientists wore a white coat, and that gave physicians and surgeons the air of credibility that they were following the evidence, that they were scientists, they were, you know, following the science and stuff like that. And so we as physicians, adopted the white coat to give us credibility and separate us from pseudoscience and quackery that was taking place 100 years ago. And it was the surgeons who first adopted it because their symbol was the barbershop pole, because the surgeons worked in barbershop poles and were bloodletting. And when you bloodlet and you lance the antecubital fossa, you'd have to put a bandage on after that. It was a white bandage, and when you walked out of there, you'd get some bleeding, and it would sort of stream down on that white bandage, and that gives you the barbershop pole, right? And so the surgeons said, listen, we want to be known more than just how quick can I take the leg off, because that was important back then before anesthetics, and how quick can I, you know, do orthopedics and surgery and stuff like that. And so we're going to adopt the white coat, and it went from there to hospital-based, and then there to office-based, and now we're pulling back. A lot of the medical schools now don't have a white coat ceremony. Still, most do, but some of them don't even have a white coat ceremony. We don't wear white coats where I am at all. You know, it's just not part of the culture.
interesting.
Oh, so what's the answer?
Know your audience. I think that's the answer.
Yeah.
That's what the plastic surgeon did. They had the expectation, and he came down, or he or she came down and gave them what they were expecting. They wanted a plastic surgeon to repair the 1 centimeter laceration on the child's forehead. Right? I work in a rural community, and you know, I come in with my Patagonia sweater on. I have to do the math. It's a 30-mile trip to where I work, 30 to 35 miles, and on Wednesdays I usually bike. And so I come in and, you know, I've got my cycling hat on, just like those glaucoma flecken videos. And I come in with my cycling hat and my Oakley glasses, and then I shower and go do the shift and then cycle home at night.
Those are great
55
videos.
kilometers.
Yeah, it's interesting, and I think there is a pitfall to the white coat, and this is not evidence-based in any way, but when you're in an office or I'm seeing a doctor, the worst thing in the world is when the collar's kind of half up and half down. You're like, oh man, this person doesn't have it together, you know? Like,
Can't even pull the coat off, right?
Can't get the collar right.
But speaking of this, now we're going to language, is that it?
Yeah, stigmatizing language.
Language, yeah. So language matters. What you say matters, and what you put in the chart matters. Right? And so this was looking at physician language and reflects upon, negative and positive attitudes towards patients. So they looked at 600 encounters with 138 clinicians and 600 encounters, 138 clinicians talking about 500 patients. So this is what they're looking at. And they had 5 major themes, whether they were negative or positive. And we've all read those notes, right? Challenging patient, difficult patient. How does that set you up and frame that when you go in and see that patient or read that note? And so there was 5 major themes, and I'm just going to run through them quickly. Questioning the patient's credibility, expressing disapproval of the patient, stereotyping based on race or social class, or the patient is difficult, and emphasizing that the physician has the authority position. And these are negative. And then they give a half a dozen other ways that you can actually put a patient in a positive light, by directly complimenting, expressing approval, the physician's own positive feeling about this, about that patient, minimizing blaming the patient. I can't believe they waited that long before they came in. What are they, idiots? Right? And I'm sure we've read notes that are just outrageous, right, with regards to negative. And so language matters, and you can put it in a positive light as well. And so the language that you use in your charting can really bias what the next clinician thinks about the patient, and it can have negative impact on that patient's care, right? They're malingering. They're always here. Difficult,
And what a medical legal risk too. If any of you have listened to or read like the Bounce Back series Mike Weinstock does, or any of these, and you go back in a case that's been litigated, and you start reading the note where 42-year-old like poor historian, this that, like a difficult patient, you're just kind of like, oh man, you're already setting yourself up in a way that like looks adversarial. You are.
And do you want to be on this?
Like
not that we're practicing law, we're practicing medicine, but do you ever want to be on the stand and going, okay, doctor, can you just read that out loud for us?
But I think you have an obligation to be accurate.
Yes.
I think you.
But you can be neutral and accurate.
You can be neutral and accurate, but if you've got, you have to justify why you managed the patients the way you did. And if your management is compromised by the patient's interaction with you or the staff, you have to put that in the chart.
Oh, absolutely.
And
Patient was swearing at me, patient took a swing at me, that's fine.
Yeah.
But that's different than saying this indigent cretin,
No, that's over the top. But saying someone's difficult or confrontational may be accurate.
I disagree. I don't think that they're difficult patients. I think that they're challenging maybe situations, but they're having a terrible day, and you only know a thin slice about that patient. Everybody has a backstory that you're completely unaware of, and their reaction may be completely appropriate if you knew the whole story. So I withhold that, and I would, I try to avoid saying that they're a difficult patient.
Well, we're going to talk about this more in the medical legal thing, because now there is the CARES Act, which allows the patients to get their medical record virtually instantaneously after you've written it. So there's a whole list of things that has been suggested, like, as an example, in the chart, the patient complains of, and the patient reads it and said, I'm not a complainer. I wasn't, so even small things that we do without even thinking of it in a negative context.
You mean calling them an SOB?
Yeah.
Okay. Well, so there's a whole list of suggestions that
Short of breath, just in case.
But I think that's what this paper is exactly pointing to, is that we're not on purpose, but like we tend to editorialize in a way that like looks, and we have biases. And I think that like some of the best times to be cognizant of these are when you're pissed off. A patient is just pissing you off, because that happens. Like I always, I tell myself every shift, I'm like, there's going to be this one. I don't know which of the patients is going to come in today, but somebody is going to get me off my game. And then when I meet that person and they're cursing at me and whatever, I'm like, oh, nice to meet you. I knew you were going to come along today. But when that person comes along and you're finally sitting down the chart, I have to be doubly careful to not editorialize on that. I'm like, my level of like pissed offness right now has to be I almost have to like double down and make sure to chart in such a way that doesn't make me feel adversarial to the patient, because I think those are the most high risk cases where, if you're feeling adversarial with the patient, I'm sure you're almost certain that the patient feels adversarial with you.
But those are great opportunities. Those are huge opportunities and windows to say, wow, you seem really upset. Is there anything else going on?
Well, I've been waiting in a waiting room for 4 hours. How about that?
Yeah.
And your triage nurse
and so
called
you
me
can
this.
and I understand. I would be upset too waiting that long. Yeah. Critical.
Sure.
Language matters. That's the take home
Language
for
matters.
this.
And that's also the stuff about emotional intelligence, that you have some kind of perception of, this
Empathy.
person's a little kind of angry. Maybe we can kind of diffuse some of this kind of. Where are we now, guys?
Number 11.
11.
Leadership, communication, stress, and burnout among frontline emergency department staff and COVID-19. This basically is a paper that trashes administrators and department leadership and blame them for the burnout from the COVID pandemic. The bottom line was, what they said was that, let's see, they found 3 things that led to burnout. One was information consolidation prior to dissemination. In other words, people waited before they gave you feedback until they got a whole lot of information. Consistency of communication. One day they were down there and there was a lot of back and forth communication. And then the third thing was specifically bi-directional communication. You said something, they said something back. You felt that the people were listening to you. Again, I find this a little bit atypical. I think, yes, there's certain leadership that didn't pay as much attention to what was going on in the emergency departments and the urgent cares during the pandemic. But I think that almost everybody knew what was happening down there. I don't think anybody's head was in the sand on this one. No. I think it's just a matter of just across the board. If a group of people feel that you are not attuned to their needs, they're not going to be happy with you.
Communication is critical. I mean, these last 2 years, I'm sure everybody in their departments, since like things were changing so fast, like mask shortages and, do we have N95s? Do we have this? And I worked at a few different places during this time, and some places were great about like keeping everybody up to date. Like on your next shift, even if it's a terrible thing that's happening, as long as you go into it with the expectation, like, hey, today there's going to be a shortage, rather than you walk into a shift, you're like, what do you mean there's no?
Yeah.
But that communication
There's no toilet
is
paper
critical.
today. What do you mean?
Yeah. Anyway, a lot of lessons learned during these last 2 years, but communication absolutely matters. And then the next paper, number 12, is there's not an abstract associated with it, but which physicians are most burnt out. If you follow Medscape, you see that every year they do this survey. The first year that they did it, actually, we were the #1 specialty.
And we're
in
still
burnout.
#1.
And we gave up that top spot for a while, and we've reclaimed it.
But yes, we're back, baby.
Good work, everybody.
So this was the stress, anxiety, and anger scale 2022, as expected. I mean, post-pandemic, this is, it's hard to imagine that emergency medicine and critical care wouldn't be at the top of this list. What is interesting, that from the year before, this was the 2022 survey looking at 2021. The year before, EPs were at 43%. We jumped to 60% in just that single year. Overall, the rates of burnout went from 42% to 47% in all specialties. And when you click through their findings, you can see all the questions and all the survey results. And so there was some interesting stuff in there. The causes, what were the causes behind the burnout? And the #1 cause for the majority of providers was too many bureaucratic tasks. That was 60%. And then a sharp drop to 39% who felt that they felt a lack of respect from admin, colleagues, staff, so a lot of interpersonal. And it wasn't until you got to number three where you got like the hours were too much or lack of autonomy. And then EHR, surprisingly, was way down at number 5, EHR, because maybe we're just, we've gotten used to like a boiling frog effect. We're just like, I don't care about saying that I'm pissed off about
Learned
the EHR anymore. Yeah, learned helplessness. But some interesting findings in here. And
Go through some of the people that like the middle of the road there.
Well, I found the bottom one was really surprising.
Durham?
Public health
Yeah.
had the lowest burnout. I mean, geez, they've had a bad couple of years, I think. And
But
being
look
harassed.
at the middle of it. I mean, diabetes and endocrinology is 50%. It's what's your blood sugar today? Okay, what's your hemoglobin A1C? All right, let's take 2 more units of I'm not sure that pediatrics I can actually see.
But hey, I'll jump back on that. With endocrinology, they're watching patients suffer and die because they don't have access to affordable insulin. And that would be like a moral injury to me. We have a drug that was created over 100 years ago by Banting, Best, and I believe McLeod. They won the Nobel Prize for it, and they gave up the patent for $1. because they said that this medicine belongs to the world. And now we have insulin prices. I just read yesterday there's some law or something in one of your states now saying it's going to cap insulin per month at $35 because it's just so unbelievably expensive
control, yeah.
to get insulin. And so if I'm an endocrinologist and I'm watching people lose their fingers and their toes and their legs and going into decay and all because they can't afford insulin, maybe my burnout would be 50%. I don't know. I'm just rationalizing for them.
There was a
All
couple.
right, do the same for the pediatricians.
Pediatricians?
There was a couple other like really important things in here, I think, just as sort of like warning signs for us to think about. In terms of coping mechanisms that they asked these docs, number one was exercise,
Drug and
fantastic,
alcohol?
48%. Well, it's getting there.
Okay.
Number
What was the first
two,
one?
exercise. So healthy
good.
coping mechanism. Number
Good.
two, isolate self. So concerning.
great.
Number three, talking with families, good. Sleep, good. And then it starts getting into that spirally kind of area. 35% junk food, 24% alcohol, 21% binge eating, and then 2% drugs. And so some of our coping mechanisms, just being aware, especially in this
Healthy versus
post-pandemic
unhealthy.
state, like are we using healthy versus non-healthy coping mechanisms? Then the depression question was, not great. 24% of respondents felt they had clinical severe depression. And 64% felt that they had colloquial depression, just sort of like day to day, but not clinically. That is 88% of the respondents that responded with those questions.
Yeah,
which
and if we're
seems
not healthy,
awfully
we
high.
can't give great health care.
And out of that, they actually asked, only 38% of the respondents previously had depression prior to their current episode. So, I mean, these trends are concerning. It's important for us to be cognizant and be taking care of ourselves during this time in a healthy way, yes?
What percent responded?
Yeah, there's always, that's a great question, and the number is almost always like right around 20% for these surveys. I don't have the exact number for this one, but I know in prior surveys that Medscape has done, it's been right around 20%.
And it was 13,000 physicians in 29 specialties.
Right.
They can respond on either end of the bell curve, I believe.
Sure.
Yeah, absolutely. I
Certainly.
think that
There's certainly a selection bias here.
yeah, people who are burned out are more likely to be filling out the survey on
That's
burned
not
out.
necessarily true because sometimes people who are burnt out are not, like they're just so, they can't do anything. They just, I'm not responding. I'm not seeking care or help or wellness
Sure.
programs or stuff. They're the least likely. So I'm not sure about survey, but I wouldn't assume that they're more likely to complain because there's a dysthymia that goes with it that I just don't have the energy, like to fill out a survey on my burnout. Are you kidding me? Really? Do I have to do a 12-page online mandatory, module on burnout too to survey how burnt out I am? So I'm not sure that would apply. I don't know is the answer.
I mean, if you fill the reply out and it bursts into flames, that's probably an indication that you're burned out.
Yeah. Well, and I have a little bit of an issue of, burnout tends to blame the individual that you're not resilient enough. The joke I usually make is I'm not suffering from yogapenia. I'm not yogapenic. Now, if you like yoga, do yoga, okay? Like if that's what you like to do and that brings you wellness and happiness, super. But all the yoga programs in the world and all the free pizza isn't going to fix a broken system. And you need to focus on system problems and system solutions as opposed to saying, you're just not strong enough. You're just not resilient enough. You've just got to really toughen up and start meditating or something like that, because then you'll be able. All your other colleagues are handling this well, So I don't want to focus on, burnout and blaming the individual and thinking it's more like a system problem that needs a system fix.
Yeah. And there's burnout and there's the depression. And the one thing we do know about depression, particularly among providers, is the more severely depressed somebody is, the less likely somebody is to seek help, which is a bad inverse relationship. Those are the ones that are most likely to self-isolate and whatnot. So I think these are just signals and important, despite a low response rate, signals to be aware of and think about like the right coping mechanisms that we can like support each other as colleagues and whatnot. All right, number 13. Physician empathy.
I wasn't aware of this, but it was believed by some that the empathetic physicians would order more CAT scans than the non-empathetic physicians, or on the scale of empathy that you would be the orderer. You want to make everybody happy, or I never was aware of this, so it's hard for me to talk about it. But in any case, out of this huge survey that was done in academic emergency medicine, 113,000 patients and 74 providers, et cetera, they looked at all of these performance metrics and validated screeners for empathy, and that theory was disproven according to this study. But I didn't know that the theory even existed, to tell you the truth.
There was a survey they did and found that physicians have less empathy than the average population. And one of the rationales behind it was that in order to do some of the things that we do, simple as sticking a needle in a little kid to give him a vaccine and make him cry, you have to have less empathy because it's difficult to do those things if you're too empathetic. I don't buy that worth anything. It doesn't make any sense to me, but the surveys consistently show that we have less empathy. And I don't know whether that's a protective mechanism or what. And I don't know. I personally, I don't know.
I
You
think
know, I
being
ignore my wife and my kids most of the time, so why should my patients be any different?
Whether or not we are empathic to like what the patient is going through, it's very clear that the compassion and advocacy piece of it matters quite a bit. And there's been a growing body of evidence around this concept of compassion. There's a book out there, Compassionomics, if anybody's looked at that. That is a really nicely done, like evidence-based review of the cost to patients and to our specialty of not being compassionate with our patients. So,
But I think there's a difference between compassion and empathy.
they're absolutely, yeah, exactly. So whether you're feeling it or not, the patient needs to know you're their advocate.
Right. Go ahead. Yes? I don't know what the empathy scores are. How do you measure them?
There's various scales out there. There's different scales out there that actually are validated to.
Look at this graph here in terms of the variability, no matter what the cause was, empathy or not. One person never ordered a CAT scan in his life, and this other one here, you know, what the heck?
Full body CT, everything coming through.
You know,
This person's working in the ankle part of the ED, ankle care only.
That's a belly pain.
Number 14.
we're just about done. You want to? Are there any others?
Well, you know,
that
I'm
think
sure
are kind
the
of-
racial disparity one will be a quick one.
That's like the.
I mean, we've already covered gender, so.
Oh yeah, it's the same
You know what's
thing,
interesting
yeah.
about the racial disparity? When I've got 15 here,
Yeah.
and I can't for the life of me figure out how this, you know, obviously there's bias and prejudice and everything else, but why that you would have less CTs in children in a children's department where everything runs by algorithm? You know, you ever see the children's departments, almost everything is you know, they're children's EDs, it's like, you know, everything's algorithm driven. How you wind up with a racial disparity there, I don't know. The only way I can figure it out is if you're comparing, and I want to see like within the same department, because if you've got a children's hospital that's in a given area where the practice is to get a lot of CTs, and that area happens to be in an area that doesn't have as many minorities as another area where the practice is not to get a lot of CTs. But it doesn't make any sense because, you know, almost every children's hospital, you ever go to their emergency departments, they're all very much algorithm driven. So I'm trying to, it clearly exists if you look at the numbers, it's there. I'm just figuring out how they were able to figure out how to get around the algorithm to let their prejudice show through.
It could be just because it's an overpowered study with 6 million visits, and so statistically it looks like that. And when you're doing odds ratios, right, you know, like, oh, look, it's 0.79 or something like that. Maybe that's because it's such an overpowered study, and the absolute numbers might be less, like the absolute percentage and differences may be tiny.
There was a few, about a decade or so back, there was a bunch of studies that came out looking at analgesics in the emergency
Right.
department, and there was racial
Under
disparities.
analgesics, yeah.
And so we went ahead and said, okay, let's, you know, this may be inadvertent, let's make sure it's not happening here. And we went in and we looked at analgesics for people getting CAT scan studies for suspected kidney stone. You know, you order the kidney stone study, CAT scan study, and could not find any difference at all. And which was very reassuring to see that we didn't have an inherent bias in our department. But that was clearly a topic for quite a while.
But both of those studies basically show that we image our black patients less often than our white patients, right? Is that, and Hispanic patients?
Al did a study in New Jersey where they looked at CT utilization, and there's all of these variables that drive it, but it was by hospital, was it, Al?
Rick was the co-author on the study, which was...
But it's culture, right? It's the culture of the institution.
Well, what we looked at, the main thing we were looking at was head CTs in children under 10, because we wanted to avoid the adolescents playing football and soccer and all that stuff. So we looked at head CTs on under 10 and compared community hospital, children's hospital, university, or whether they had a pediatric ED, didn't have a pediatric ED, who saw them and everything else. And the spread was just ginormous.
Yeah, this was like every hospital in the state of New Jersey. And it was like, man, oh man, if you wanted to kind of get a hold of some of the costs in medicine, you would kind of look at this distribution and say, how do we affect this in some way?
Yeah, well, both of them just show that healthcare disparities exist, and they do. And we need to fix that too.